My name is Tomáš Hájek. I'm a professor of psychiatry at Dalhousie University. And thank you, Ben, for inviting me to this very interesting symposium. I have no conflict of interest. And before I start, let me put things in a bit of a perspective. So, as you know, our brain is the most complicated matter in the known universe. And if the brain was so simple that we could understand it, we would be so simple that we could not. So while we may never be able to breach this philosophical boundary, the hope was that with the advent of brain imaging, we will be able to get really, really close to it. And I think that has happened. Brain imaging has really exploded the knowledge about the biology of major psychiatric disorders. However, as a clinician, I think it is fair to say that brain imaging has over-promised and underperformed. And there's very little in terms of brain imaging that would be of use in the everyday practice of clinical psychiatry. And my thoughts about this is that the main reason why brain imaging has not sufficiently informed clinical psychiatry has to do with the fact that clinical psychiatry has insufficiently informed the brain imaging research. And here I'm talking about clinical heterogeneity, which is obvious to any clinician. That's really the bread and butter of our work. We know that every patient is different, yet this knowledge somehow does not percolate into brain imaging studies, which oftentimes act on the assumption that there is a prototypical bipolar patient, which can be compared to a prototypical patient control, for example. And until we get much more information about the participants in the brain imaging studies, we may not be able to correctly identify or understand the phenomena that we observe through the lenses of MRI scanners. And let me give you an example of that. Here is a meta-analysis of amygdala volumes in bipolar disorders. Now you can show a similar figure for any other brain structure, any other brain imaging modality. You can show the same picture for essentially any other psychiatric diagnosis. What you see here is marked heterogeneity of results. You can see that in many instances, studies did not find differences between patients and controls in amygdala volumes, but there are also some studies which found smaller amygdala volumes in patients than in controls. Other studies have found larger amygdala volumes in patients than in controls. And I suspect that this statistical heterogeneity actually reflects the clinical heterogeneity. It also clearly demonstrates that when we see differences in brain imaging findings within a diagnosis, that means that there has to be other factors that play a role beyond just the diagnosis. And it is very important to ask ourselves which of the clinical factors underlie the neuroanatomical or neurochemical changes in bipolar disorders. And for example, we know that some of the brain changes can be related to the genetic risk for the illness. We know that some of the changes are secondary to the illness scores and illness burden. We know that medications affect the brain structure. But in here, I want to specifically focus on the comorbidities. And I'm not talking only about psychiatric comorbidities, I'm more talking about medical ones. And my thesis here is that the presence or absence of comorbidities may explain why some individuals with the same diagnosis show more pronounced changes than others. I propose that maybe some of the brain changes in patients with bipolar disorders are better explained by the presence of comorbidities than by the presence of bipolar disorders, essentially. Now, comorbidities may also help us understand another interesting fact. If you look at the patterns of alterations in bipolar disorders from some of the largest studies, such as the Enigma consortium ones, and at patterns of changes in schizophrenia, they are remarkably similar. They're overlapping to a great extent, which is surprising because the patients are not that much similar. So I, again, would propose that maybe the shared comorbidities among these conditions explain the shared neuroimaging alterations between them. And one comorbidity which is associated with both schizophrenia and bipolar disorders, and which also is known to affect the brain structure, is obesity. Now, as we know, about 50% of patients with bipolar disorder or schizophrenia suffer from obesity, which is significantly more frequent than in the general population. And this has clear implications for the somatic health of our patients, the aforementioned increased mortality and much shorter life expectancy. These issues are starting to receive more attention now with, for example, the Lancet Psychiatry Commission. What is much less recognized, but probably as important, is that the presence of these metabolic comorbidities has an influence on the psychiatric outcomes. Long before these conditions actually increase the mortality, they may contribute to chronicity of the psychiatric illness. They may increase the symptom burden. They may contribute to disability, lower psychosocial functioning, as well as poor response to psychiatric medication and also suicidal behaviors. And that is puzzling. Why does a peripheral metabolic disorder affect the brain outcomes? And my suspicion is that the pathoplastic effects of obesity on psychiatric outcomes may actually be related to the effects of obesity on the brains. And I'm very thrilled that the ISBD Vascular Task Force manuscript, which recently came out, outlines some of these complex relationships, and I would urge you to read that. Now, indeed, obesity is negatively associated with global as well as regional brain structure. That evidence is highly replicated and was shown even in the largest studies to date in the UK Biobank and in some other large community samples, as well as in a recent meta-analysis. The regions which are most affected by obesity include frontotemporal regions as well as cerebellum. Now, despite the high prevalence and impact of obesity in bipolar disorders, the effects on brain structure or function in bipolar disorders or any psychiatric illness are markedly understudied. If you search in Medline for brain obesity and MRI, you get 1,400 manuscripts. If you add bipolar disorders to that, you get 16, and maybe 3 more in schizophrenia. So this really does not reflect the impact these conditions have on our patients. And I'm glad that this symposium and other work is starting to make that argument that we need more research into this. There are some studies in bipolar disorders which have shown that even there obesity is associated with measures of brain structure, that it is manifest already in people who are at genetic risk for the illness, as well as in young patients with bipolar disorders, as well as in those with first episode of mania. The regions which are affected in bipolar disorders by obesity are similar to those in the controls, including the frontotemporal regions as well as the cerebellum. Interestingly, some of these studies have suggested that maybe there are some additional regions that are affected by BMI in bipolar disorders, or that there is an interaction between BMI and the illness, that the effects of BMI may be more pronounced in bipolar disorders, which is definitely concerning and worth investigating more. In schizophrenia, we have shown that both obesity and the history of first episode psychosis were associated with increased brain age, and that the effect of these 2 factors was additive, such that normal weight controls their brain age was essentially comparable to their chronological age, whereas overweight or obese participants with first episode schizophrenia, their brain age was significantly greater by about almost 4 years than their chronological age. No study yet has investigated the localization of obesity-related neurostructural alterations in schizophrenia, which is what we aim to do here. And to do that, we looked into this in the early stage of schizophrenia study, which has been done with my collaborators in Prague, Czech Republic. To ensure generalizability of the sample, we recruited participants from a large-scale general psychiatry hospital, which is about 1,200 beds and serves Prague and the central Bohemian region. Inclusion criteria were first hospitalization for a diagnosis of schizophrenia or acute and transient psychotic disorders. Patients had to have less than 24 months of untreated psychosis and had to be 18 to 35 years old. We also recruited controls without lifetime or personal history of psychosis. Now, we acquired whole brain 3D T1 weighted scans on a 3D scanner, and within 1 week we acquired some anthropometric clinical information and obtained a fasting blood sample. Here is what it looks like when you unleash psychiatrists in a lab. The analysis we did were voxel-based morphometry analysis based on a pre-registered analytical plan. So overall, we recruited 120 participants with first episode psychosis and 114 controls. The patients were in the early stages of the illness and in the early stages of their treatment as well. As you can see, on average, the BMI did not differ between the groups, but there were more overweight, obese participants among those with first episode of psychosis. Here are the results. So when we controlled for BMI, we saw that the history of first episode psychosis was associated negatively with regional brain volumes, especially in the left inferior frontal gyrus, superior temporal gyrus, temporal pole, insula operculum. There was a sizable cluster of 395 voxels, which showed this association. When we controlled for the first episode of psychosis, BMI remained significantly associated with primarily cerebellar volume. Interestingly, both first episode psychosis and BMI were additively associated with lower cerebellar volumes. Now, our findings of association between the frontotemporal volumes and first episode of psychosis are very much in keeping with previous meta-analysis in first episode of psychosis. And they support the importance of these regions in psychosis. Importantly, these regions are relatively unaffected by potential confounding through high rates of BMI or obesity in first episode of psychosis. Our findings that BMI as well as psychosis were associated with cerebellar volumes is also in agreement with previous meta-analysis showing association between BMI and cerebellar volumes. It is also in keeping with a meta-analysis and the largest study of cerebellar volumes in schizophrenia, which showed lower volumes of cerebellum as a whole, as well as some parts. The effect size for this difference was relatively small, was about 0.3, and neither of these studies controlled for BMI. And because of the additive association, it is fair to say that the differences between the groups would probably be much lower, and the patterns of findings would be much less consistent if they did control for BMI. And in future studies, especially those focusing on cerebellum, need to take the BMI into consideration, because that is one factor that also affects the cerebellar volumes. Taking that into account would also markedly change the interpretation of findings. For example, A very recent study that just came out in May showed that the only region which showed abnormalities in people who are at risk for schizophrenia, at risk for bipolar disorders, or at risk for MDD were lower cerebellar volumes. And they concluded that the reduced cerebellar gray matter might represent the brain structural correlate of a shared vulnerability across psychiatric disorders. Well, maybe this actually represents not shared vulnerability for psychiatric disorders, but shared vulnerability for obesity. That also would need to be considered. And we need cross-sectional or cross-diagnostic studies that would take BMI into consideration. Now, since this was a cross-sectional study, we cannot really establish the temporal direction of the association. While I suspect that obesity, that the brain changes are a consequence of obesity, it can also be the other way around. It can also be that certain brain alterations predispose towards obesity, maybe through increasing impulsivity or causing some other homeostatic dysregulation, which makes people maybe overindulge and be more likely to gain weight. That has been supported by a very elegant study which found that actually the genetic risk for obesity was mediated by prefrontal volumes. However, the localization of our changes in the cerebellum would not support this reverse causality. Now, there are many reasons why obesity may affect the brain. Foremost among them, one is to consider the atherosclerosis. At the same time, we excluded any macrovascular events, and we focused on young diabetes-free participants who had very low rates of hypertension. Also, we found no association between vascular risk factors and brain imaging measures in the regions which were affected by obesity. So that makes it less likely that the results were secondary to false plumbing, essentially. But we did not have some of the preclinical or fancier measures of atherosclerosis, such as the echo or the arterial spin labeling or the pulse wave velocity. So we cannot completely rule this out, but it seems to be less likely in this cohort. There are a number of non-vascular reasons why obesity affects the brain. Foremost among them is the systemic inflammation. We know that weight gain is associated with increased secretion of adipokines as well as some inflammatory factors. And also the obesity leads to accumulation of and recruitment of immune cells such as macrophages and lymphocytes. Interestingly, we did find a very strong association between obesity and systemic inflammation as measured by the C-reactive protein, and also the C-reactive protein was negatively associated with the gray matter volumes in the regions that were associated with obesity. Now, another thing that one needs to consider in interpreting these findings is obviously the medications, which can contribute to both obesity as well as some regional neurostructural alterations. And we need more research into this, because the role that obesity plays in some of the negative effects of medications on the brain has not been studied, and this is extremely interesting. In our data, we did not see any association between antipsychotic treatment and gray matter volumes in the obesity-related regions. It's probably related to the fact that these patients were at the very early stages of their treatment within 2 months of starting the treatment. This may look somewhat different when after a longer duration of the treatment. So to conclude, comorbidity with obesity could contribute to heterogeneity of neuroimaging findings in bipolar disorders or schizophrenia. The effects of psychosis were most pronounced in frontotemporal regions, whereas the effects of body mass index were most pronounced infratentorially in cerebellum. Systemic inflammation could contribute to obesity-related neurostructural alterations, and we need longitudinal studies to clarify the direction of association and the underlying mechanisms. And I would very much like to thank all my friends and collaborators from Czech Republic and Canada, and thank you for your attention.